Hi, my name is Dr. Ruth Arumala, and I am an obstetrician gynecologist in Mansfield, Texas, right outside of Dallas, Texas. I am also a newly appointed associate professor at TCU, joint collaboration with UNT, to create this wonderful new medical school. And I'm so excited to be a part of this new movement. Well, I wanted to talk to you today about preparing for an OBGYN rotation. You know, this can be really about both a third and fourth year rotation, but I'm going to focus on a third year rotation because most of the fourth year medical students that will be doing OBGYN rotations will be doing active internships, and I want to talk about that separately. But you can extrapolate some of the advice I give in this video if you are going to be an acting intern. So before you start, if you are in a traditional medical school, you're probably going to be doing either a 4 to 8 week rotation. Sometimes some schools have a little bit longer. So you probably will get a mixture of labor and delivery, where we take care of women in active labor, some women who are coming in for triages and immediate postpartum care. You might be working in the office setting, like in my office, and you might be doing GYN surgery. And if you are lucky, because I think this is really important, you might go out to some of our subspecialties such as family planning, reproductive endocrinology, and infertility. Those are called the fertility docs. You might get some breast rotation, really interesting because breast can be both OBGYN and general surgery. You might get some rotations at the GYN oncology departments, which is when we deal with cancers, gynecologic cancers such as ovarian, endometrial cancer, cervical cancers, and that kind of thing. So you might get a good mix. So it's good to know, if you can, what your rotation is going to look like, because that will help you adequately prepare. But I will say that most people are going to be on labor and delivery, so we'll start there. For labor and delivery, some of the things that you need to know is how to do a proper triage. So what does it take to do a proper triage? Triage, you're trying to get as much information. And as a third year medical student, that is your job. You need to learn how to adequately and completely collect information that can be conveyed to your superior to be able to get as much information about this patient so that you can adequately diagnose and treat the patient. In addition to that, you're going to want to work on your efficiency, so you're not taking a history and physical or even just a history. Ways to go about doing a triage are, you can start off by just asking the person why they're there. That's called the history of presenting illness. In OBGYN, we use specific kind of wording. So we use the age, the G's and P's, which are the gravida and parity of the patient. Gravida is how many times you've been pregnant altogether, and parity is broken down into how many pregnancies you actually have delivered or had abortions. And abortions in medicine include both spontaneous abortions, which are also considered miscarriages, and terminations, which are considered, some people call them TAB. And so the way that it's set up is the first letter, so the G is going to have a number right after it, and that number is how many times a person has been pregnant. And then right after that, there's going to be the P, and then the first number is how many term pregnancies. And actually, it's term is defined, and we have a lot of definitions in OBGYN to be greater than 37 weeks and up. So 37 weeks and 0 days is term. Preterm is less than 37 weeks, but after 20 weeks. So 20 weeks to 36 weeks and 6 days. And so that's the next number. The third number is anything from conception to 20 weeks. That will usually house most miscarriages and most abortions or spontaneous or terminations. And then the last number is going to be the live infants that were born. And so let me go over that again, because that can be a bit confusing, and it's also even confusing for me to say. So gravity is how many times you've been pregnant, and then parity is broken down to 37 weeks and up as the first number. 20 weeks to 36 weeks and 6 days. That's the second number. Third number is from conception to the 20 weeks. And then the last number is the number of live births. So if you have a patient that has a G5P2032, that would mean that the person has been pregnant 5 times, has had 2 full-term deliveries, 3 miscarriages or abortions, and 2 live births. I hope that makes sense. So I'll have it written out also so that can help you. But you need to know those basics because that's how we talk. And then, so we have the age, we have the G's and P's, and we can have sometimes, then the next is the dating. So that you'll say, okay, this person is a 26-year-old G5P2022, meaning she's currently pregnant. She is at 36 weeks and 6 days. So you always have to put the weeks and the days, okay? And that kind of helps an obstetrician kind of come up with triaging them in their mind, what they could be there for. Because if they're presenting for rupture of membranes at 36 weeks and 6 days, that's preterm premature or preterm rupture of membranes because it's less than 37 weeks. And then you're going to say how the person is dated. Are they dated by their LMP, their last menstrual period? Are they dated by their LMP that's consistent with an ultrasound, such as the first trimester ultrasound? Are they dated by an LMP that is not consistent with a first trimester ultrasound? Or are they dated by like a first trimester ultrasound? So you would try to figure that out probably from their office notes, you know, how they are dated. And then you'll say why they are in triage. So many of the most common reasons why people come to triage are for, it's because maybe they're having contractions and you're trying to rule out labor or preterm labor. They feel like their bag of water broke, leaking of fluids, so you're trying to rule out preterm premature rupture of membranes or just premature rupture of membranes. Decreased fetal movement, so you're trying to assure fetal well-being, or if they have vaginal bleeding. So those are the common 4 reasons. Of course, people could come in for nausea and vomiting. They can come in for abdominal pain, nausea, and vomiting, and be found to have appendicitis, right? You don't stop being a human being because you're pregnant. So there's so many other reasons why they could come in for a UTI. They could come in for a yeast infection because now they have copious discharge, and yeast infections are very common in pregnancy. So that's kind of what you're going to try to get in your H&P. You're going to try to get supporting facts. Like, how long have these contractions been going on? Are they increasing in frequency and intensity? When they felt like their bag of water broke, was it one large gush of fluid, or was it little trickling? Has it continued? Because sometimes women can urinate on themselves and think that their bag of water broke, or they could have their mucus plug could become unearthed, and that could actually present really dramatically, and some people think that's their bag of water. Those kind of things. Vaginal bleeding, you want to know, is it painful? Is it painless? You want to palpate their abdomen because you're trying to figure out, are they abrupting, having a placental abruption? Do they just have, post-sex intercourse or post-intercourse vaginal bleeding? Those are questions that you're going to try to ask so you can piece things together. So you get some supporting facts. And it kind of helps to know the diagnoses. Like, for instance, what does it mean to be in labor, where you have regular contractions that are changing the cervix? That's the definition of labor. Whether it's preterm or term depends on the gestational age. What is the difference between PPROM and PROM, or premature rupture of membranes, and preterm premature rupture of membranes? What are some of the differential diagnoses for third trimester vaginal bleeding, which can include placenta accreta, placenta previa, placenta abruption, and any placentation issues can cause bleeding. Sometimes women have polyps in their cervix that can cause bleeding. They have other reasons. Sometimes it's trauma from intercourse, like we just mentioned. So knowing some of those basic things kind of help you and lead you one way or the other. Decreased fetal movement, you want to know like a lot more, and usually by the time you even get to see the patient, if they came in with decreased fetal movement, the nurse would have already put a fetal heart monitor and a tachometer, which actually measures the pressure of the uterus to see if you're having contractions or not, and that you can see whether or not you have a heartbeat probably before you go in there as a medical student. If you cannot hear a heartbeat, call the nurse, try to help her, tell her to get a heartbeat of the baby. And you can also call a senior resident, because that is an emergency if there is no fetal movement and no heartbeat. Okay, so those are some of the things that you'll be asking in your history of presenting illness. And then you do a review of systems that will consider all the entire body, but focusing on obstetrical areas such as contractions, leaking of fluid, vaginal bleeding, and whether or not you're feeling the baby move. Those are the 4 cardinal things you must go over during a review of systems. Again, contractions, leaking of fluid, vaginal bleeding, and whether or not you feel the baby move. So woosah. Those are the obstetric parts. Now you're going to get more of the history. Past medical history, past surgical history, medicines, allergies, the social history that will include, do they smoke? Do they not smoke? Are they on cocaine? Are they not on cocaine? Do they take marijuana? Because sometimes, like for instance, with marijuana, you can have people take marijuana because they're trying to, some people use marijuana because they're trying to reduce their nausea and vomiting, but they can have paradoxical increase in nausea and vomiting and intractable vomiting when it comes to marijuana use in pregnancy. So you want to know all that stuff. And then you can ask about family history, which is usually in this setting, you want to ask about genetic disorders, especially if this patient has had no care. And some of the fancy ways, and that's really how to do the history. And then the physical always involves, you always want to do general, whether they're in distress or not. You want to do a heart and lung exam, and then you do an abdominal exam. And then the things that are specific for OBGYN is you want to try to look at the fetal heart tracing. So before going on labor and delivery, one of the things that I would employ you to do is to look at and learn how to look at the fetal heart tracing. It's like the EKG for us, because we're looking at the fetal heart tracing and its relation to how the uterus is behaving. So whenever you're presenting a fetal heart tracing, some of the things that you can present include the baseline of the heart rate. So the fetal heart rate, what is the baseline? Normal baseline is between 110 and 160 in the 3rd trimester, and you want to be able to describe that. And that's going to be the average of the baseline. And then after that, you want to talk about the variability. So that's the beat-to-beat changes in the fetal heartbeat. So there are 4 different categories. It could be absent, minimal, moderate, and marked. So you want it to be moderate. And moderate is if the beat-to-beat changes between 5 and 25 beats per minute. Next, you want to talk about the accelerations. And I'm giving you like a really fast so that you kind of know what to look for, but you're going to read about this. You're going to have to read about this. And it is actually available on a practice bulletin where you can read about it, but I'm sure there are other sources, particularly your medical school textbooks, that go over this in detail. So accelerations are broken down if you are less than 32 weeks or greater than 32 weeks. So less than 32 weeks, it would be that the rise from the baseline is 10 beats per minute or greater that lasts at least 10 seconds. And with greater than 32 weeks, it will be 15 beats per minute that lasts greater than 15 seconds. And it's a symmetrical move from the baseline, literally goes like this, goes up, over, and then continues on the baseline. And then you talk about decelerations. Accelerations are great. It would be like if you were jumping up and down, your heartbeat would go up. Well, if the fetus is, moving around, the heartbeat will go up. So that's great. And then the decelerations is when there is a rapid or there's a drop from the baseline down, and they have different patterns. Some of the patterns include late decelerations, variable deceleration, and early decelerations. I'm not going to go into detail about that because I can make a whole video, and I should make a whole video about that. But you need to know, my point is, you need to know how to read a fetal heart tracing, because you're going to be doing that immediately when you get on. And it will also help you understand why people are running to one room or not running to one room based on the fetal heart tracing. Okay? And then you look at the tachometer, which is usually the bottom, and it tells you what's happening with the uterus. When it rises and falls, is the pressure of the uterus is also rising and falling. And there are different ways to look at it, particularly if you have an external monitor versus an internal monitor. And that, again, is a whole different topic. So far, you should know how to do a history. You should know how to do a basic physical that includes reading the fetal heart tones. Now, you probably, and I wouldn't ask any medical student to learn how to do a cervical check. That's for the interns, fourth-year medical students, perhaps interns and residents and attendings, obviously fellows. So that's a little bit more, but that's really trying to figure out the changes in the cervix, which include effacement, which is a thinning of the cervix, and the cervix has to thin out to be paper thin. Dilation, which means opening of the cervix. Station, which is where the fetal head is with relation to the cervix and the outside world and inside world. And whether or not the location of the cervix is anterior, posterior, or mid in the vagina. Does the cervix, is it all the way up? Is it in the middle? Is it all the way down? And then we also try to figure out if the cervix is soft, hard, and all of that. We're trying to come up with a Bishop score. We don't really use Bishop scores just for, it kind of helps us, but we use it more for inductions to figure out what is the right induction agent. Okay, so that's kind of more advanced, but you want to be able to do that. And then that kind of probably concludes what you're going to be able to do in the beginning in triage. And then you can go with your resident, intern, most likely the intern, and they will do an ultrasound to see the position of the baby to make sure that the the presenting part is the head versus any other presenting part that is a malpresentation. They're also probably going to assess the fluid around the baby to come up with either a maximum vertical pocket or an amniotic fluid volume. And they're also probably going to be doing looking at the placenta to see the position of the placenta and look at other placental health issues. So that is kind of the history and physical, and then they'll come up with a plan. Usually the plan is, are we going to keep this patient and deliver this patient, or are we going to send the patient home? And that's literally what L&D triage is like. On a regular basis, you want to be helping with looking at the strips, which is the fetal heart tracing, and you want to be able to know when something is wrong and when something is right, and helping write strip notes. If you have patients that are, so in general, you need to know how to do a regular H&P. You want to know the basic things that people present into labor and delivery with. You need to know how to look at the fetal heart tracings, usually those on day one. Now, some other things that would be really helpful to you would be knowing a little bit about preeclampsia, because that you might be able to help with writing magnesium notes when patients are on prophylactic magnesium for the management of preeclampsia with severe features. So I would read a little bit more about preeclampsia. And then lastly, one of the other things that you would need on labor and delivery is to be able to write postpartum notes. That's usually the first thing that you would do on your rotation, because it's in the morning, right? Really, really early in the morning is when we do postpartum rounds as residents and interns and medical students. So when you walk in to see a postpartum patient, you want to know, did the patient have a vaginal or a C-section? And how far out are they from vaginal or C-section? Is this postpartum day 1? Is it post-op day 2? What day is it? So if it's a vaginal delivery, what you want to ask is if the person has really returned to activities of daily living, such as are they able to tolerate food without any nausea, anti-nausea medication? Is their pain well controlled? Did they have a large laceration, like a 3rd degree or 4th degree? Are they on stool softeners? Are they able to defecate? Those are questions. Have they been out of bed? Have they been walking around? Of course, you're always going to listen to heart and lungs, and then you kind of want to screen them for their affect to make sure that they don't have postpartum blues right away or postpartum psychosis. And then when we talk about the post-op patients, these are people who went through a C-section and they have had an operation. So you want to take a little bit more time to look at their incision, make sure that they are not nauseous, that they've been out of bed so they don't form a postpartum ileus, which means that their intestines aren't working as well. You want to make sure you take the post-operative care, make sure that they're using their spirometers so that they don't have atelectasis, which is collapsing of the lungs and the alveoli. So you want to listen to their lungs, make sure that they don't have, they're passing air freely. You want to make sure that they've been out of bed or they have SEDs, which are sequential compression devices that help with the lower extremities to move blood around so that they don't get a deep venous thrombosis or DVT or, consequentially a PE. So those are the things you kind of want to do. Universally, you want to ask about breastfeeding. You can ask about postpartum family planning, like do they plan on getting Depo? Do they want to get IUD or Nexplanon? There's some things we can do on labor and delivery, and there's some things we can't. So we'll talk about that in a different video. And then you also want to make sure that their affects, I started to say that for the vaginal deliveries, but for both women, that their affect is appropriate. If they have a history of a mental disorder, you want to make sure to take particular attention, make sure that they're not suicidal or homicidal with the large drop of estrogen and the new infants that is now theirs, right? That can really, it's now a new change in phase, and in my reality might hit them. So you want to make sure that you look into that. So that's postpartum rounding. It can be fast, it may be slow. There might be language barriers, but make sure you do a good job. And one of the ways to make sure you do a good job is if you show up to the hospital early. So that's labor and delivery. If you are on GYN, GYN comprises of the emergency department consultations, floor consultations, and the operations. So you will show up and talk to your senior, and they'll discuss with you how they want you to be separated. So sometimes you'll be in the OR, sometimes you'll be in, and I actually neglected to say that you might be in the OR or delivery room with on labor and delivery. So for C-sections, one of the biggest questions that I always ask medical students, well, I don't really ask it, I usually tell you guys, but a lot of other people ask, which is the layers of the abdomen, like going from the skin into the peritoneum. So I would memorize that and know that, because that's going to be really helpful to you. The other thing is, if you're in a C-section, you want to eat before you go, especially in the beginning, because sometimes seeing that amount of blood can make you queasy. You also want to make sure that you're moving your legs when you're standing so that you don't lock out your legs. And let someone know if you feel queasy, you feel like you're about to faint. Full disclosure, my first C-section, I almost fainted. I tried to walk it through. I didn't eat breakfast. I was trying to be slim, and I was trying to pull it off. And I almost passed out, and I almost passed out onto the patient. And that happens very often, especially your first, if that's your first surgery. You're under the bright lights, you're not used to it. So sitting down is okay. It doesn't preclude the fact that you can never be a surgeon, because here we are, here I am. I still operate, 2, 3, 4 times a week, depending on the week. So you can still become a surgeon. and you can still become an OBGYN, so don't let that deter you. So even in, the other thing I want to tell you about is in vaginal deliveries. Vaginal deliveries, you want to be the more of the helper unless you're asked, and see a couple before you're asked to deliver. Some people will teach you earlier than others. Some people will never teach you. That's okay. Being part of the team is enough for you to learn about vaginal deliveries and about repairs to the vagina. It might also let you know if this is something you'd be interested in as a career. So we'll go back to GYN surgery or GYN rotations in general. So in the emergency department, some of the things that we see most commonly are pregnancy of unknown location. So we don't know where the pregnancy is. The person is early pregnancy, comes in with abdominal or pelvic pain, and also may have they may have some vaginal bleeding, plus or minus vaginal bleeding. So what we're really trying to make sure is, one, is this pregnancy viable? Meaning, will it be able to progress past now? And number two is the location. So is it in the fallopian tubes? Is it in the uterus? Is it in the ovaries? Is it somewhere else that it shouldn't be in? And so that's kind of what we're trying to figure out with pregnancy of unknown location. So I would encourage you to read about pregnancy of unknown location. Again, a whole nother subject that we can discuss in a different video. The next thing that we're going to talk about, or that is very, very common, is people that have some kind of pelvic pain, and pelvic pain and or vaginal bleeding that is heavy and it's not going away. So pelvic pain, we could be dealing with somebody that has fibroids, endometriosis, adenomyosis, all different topics. And then heavy menstrual bleeding could be actually heavy menstrual bleeding, or it could be that you have abnormal uterine bleeding because you've had anovulation, you haven't ovulated. Big words, but those are the basic things we see in the emergency room. So we could talk about how to deal with that. Sometimes we might see a pelvic infection known as PID. Sometimes you might see that, or some kind of adnexal or ovarian mass there, such as a teratoma or a cyst that either ruptured or didn't rupture, or a ovarian torsion. So again, all these little subjects, if you're interested, I'm going to go in and discuss each one of those, okay? With GYN surgery, we usually are doing either some kind of adnexal surgery, like cystectomy, or bilateral salpingectomy, which is removal of the fallopian tubes for contraception. Sometimes we do it for the prophylactically for patients who have increased risk of having a malignancy or cancer in that area. So that's one of the reasons. The other most common reason is to do some kind of hysterectomy. There are different routes of a hysterectomy: vaginal hysterectomies or total vaginal hysterectomies, and that's usually abbreviated TVH. And then we do total laparoscopic hysterectomies, which are TLHs. And we could do a laparoscopic assisted vaginal hysterectomy, meaning that we start up top, get down to the uterine arteries, and complete the hysterectomy from below, from the vagina. We could do a total abdominal hysterectomy, which is the old school way, which we still do. There are many reasons to still do them, either a fat and seal or a horizontal incision or a vertical incision. And you'll see a lot of the vertical incisions done in oncology, in the GYN oncology realm, because they sometimes have very extensive disease, particularly in ovarian cancer. And sometimes you'll see it done with really large uteri that have fibroids in them and different things like that. So you kind of want to know, what is a hysterectomy? And a hysterectomy is basically this: the removal of the uterus by removing all the ligaments and blood vessels and removing the uterus safely from the body, and then reapproximating the vagina. We call that the vaginal cuff, And then also making sure that there's no bleeding and that we did not harm the ureter. That in a nutshell is what a hysterectomy is. The different routes you'll learn as you go along. Basically, your job is to help retract a lot so that we can see what we're doing. The more hands, the merrier if it's really helping. So one of the tools of the trade is that when you retract, it's not the power that you use, it's the angle. So I used to come back with pinched nerves because I'm spending all my time like really pulling, but that actually can cause the patient a lot more pain, and you're not really doing that much help. So just always think, if I cannot see what the surgeon is working on, then the surgeon cannot see either. And it'll take a while for you to know how to retract and how to pull things away, so that other tissue away, so that the actual meat of what we're working on is now very apparent to the surgeon's eyes. You know, a good surgeon is only really good when his assistants are really good, and you are considered a surgical assist. So that is GYN in a nutshell. And then we'll go to office. Office, usually we're seeing pretermers. We're doing antepartum care, which is before you deliver. And then we're doing postpartum care. We might see patients for any number of reasons. Like I see a lot of menopause patients that have sexual dysfunction, fibroids, abnormal uterine bleeding. So you'll be prepared for everything. And office is basically a lot of just observation and getting to know the different topics. So I think that really encompasses what you should expect on your GYN rotation, your OBGYN rotation. I hope that helps. If you have any specific questions and you want to put them down below, I'll be happy to answer them for you. So again, my name is Dr. Ruth Arumala. I want to tell you a little bit of some of the things that I am doing in case you're interested, and I want you to check them out. So everything that I do is housed on my website, www.drumala.com. I also have an Instagram page, i.am.dr.arumala. I also have a podcast, and the podcast discusses everything, all things women, particularly for you as a medical student. We had a recent episode that you might want to check out. So I want you to go over and check it out. It is available everywhere that you listen to podcasts, including Apple Podcasts, Spotify, SoundCloud, and you can actually just listen on our website. And then we also have a Pretty in Pink Pod IG page. So that was a mouthful. I hope, again, this particular video helps you to get more acclimatized and kind of know what would be expected of you in your OBGYN rotation. I wish you the best of luck. And some nuggets that I want to leave with you are, make sure you read every night. Some of the places to read are the American College of Obstetricians and Gynecologists. ACOG has the practice bulletins. I will read that. There are small little medical student textbooks that are really helpful. The Case Secrets, I don't know if you guys still have that, but it's very, very helpful because it walks you through cases. And then, you can always ask your particular intern or resident what they would recommend that you read so that you can get up to speed as fast as possible. But read every night, even if it's 10 to 15 minutes, read. The other thing is, I want you to continue to do questions. If you have purchased UWorld for the year, continue to do questions because they'll give you scenarios that will bring real topics to life for you and help you juggle your memory in a different kind of way. And it's a really interesting way to learn. Third is, don't be scared to ask questions, but try to ask questions that cannot be derived by Googling or just searching for it. Try to ask questions that have to do with experience. Be very cognizant of when you ask questions. Try not to ask questions while the patient is there or when the resident or attending seems really stressed. You are, in addition to the team, a very valuable one, but you don't want to retract You don't want to take away energy from the patient or from other things that are going on in the attending's life. And that will help you in every rotation to be sensitive that you are not the only person there. These attendings are really stressed. These residents are super, super stressed. And so they need a little bit of reprieve for themselves. That's really it. That's all I have. I wish you the best of luck. Please, please, please give me a comment in the comment section to tell me if this video has helped you at all. And you can leave it even after your rotation is over. So it has been really good talking to you. Again, my name is Dr. Rumala, and I will talk to you on the next video really, really soon. Bye.